So I'm going to talk about quality of life in brain tumour for brain tumour patients. And this is something that neurosurgeons often don't think about. Neurosurgeons think about the surgery and then they don't think about what happens after the surgery. But this is vitally important because, as we all know, in this picture up in the top corner, one of my patients at her 21st birthday, at her wedding, looking beautiful, and then 15 years later, after she's finished her brain tumour treatment with the steroid Cushingoid face, what you can't see there is the hemiparesis, and all the terrible difficulties that she's gone through in her life after the management of that brain tumour. So this is not for our patients just about the surgery, it's about everything that happens afterwards. And we need to pay attention to that. We need to pay attention to it for every kind of tumour there is, and it needs to be personalised to the patient, their tumour type, their tumour location, the point that they are in their life. Obviously, treatment for a 65-year-old who's just retired would be very different for a 30-year-old who's just had a baby. So the WHO definition of health is something that's important, and it's a state of complete physical, mental and social well-being, not just the absence of disease. So who's completely healthy here in the audience today? Anyone completely healthy in the, no headache, no anxiety, nothing to worry about? Yeah, no one. So firstly, no one is ever completely healthy. But when we think about health-related quality of life, that is the quality of life associated with ill health and its treatment. And it's become a really, really important metric in lots of studies. So in studies looking at chemotherapy, whether it affects quality of life, in studies looking at different surgical strategies, in studies comparing different sorts of treatments, surgery versus radiosurgery. All of these things are now look at quality of life as an outcome. And health-related quality of life is affected by treatment factors, patient factors, and tumour factors. All of those things relate to quality of life. And the health-related quality of life is self-assessed. It doesn't matter what the neurosurgeon thinks. It doesn't matter what ASME thinks the patient's quality of life is. It's all about how the patient feels. So it's not about what the surgeon thinks. Self-assessed, multidimensional, that encompasses physical, emotional, and social components of quality of life associated with illness and its treatment. Now, I felt in my clinic when I started this research that I did not understand my patient's quality of life. The acoustic neuroma patient came in. I'm dizzy, I can't hear, I feel terrible, my life is awful. And yet the low-grade glioma patient would say, I'm okay. My scan is good. I'm happy. So I didn't understand quality of life in the patients, and I needed to start studying it. So we started a study, which is now 9 years ago, where every time the patient came to the clinic, we measured their quality of life for low-grade glioma patients, meningioma patients, and acoustic neuroma patients. And I figured that that would allow us to have a disease that means that we could get a long view of this patient's quality of life. And our questions were, and these were all post-operative patients, what are the determinants of their health-related quality of life? Are there longitudinal changes? Does it get better? Does it get worse? What interventions could improve health-related quality of life? And what was actionable? I didn't really care if I found out that left-sided tumours had worse quality of life than right-sided tumours because I can't change that. So what would be actionable in my clinic? So I had an army of medical students who all got a little research paper out of this. They went out into the waiting room with the questionnaire, and they got every patient to consent and fill out the validated health-related quality of life questionnaire, the QLQ-C30 and the QLQ-BN20, which is specific for brain tumours. It looks like this. These are the sort of questions that it has on it. So looking at functional scales for physical, role, emotional, cognitive and social functioning, some relevant symptoms, and it's scored on 1 to 4, not much to a lot, or not at all to very much, 1 to 4 or 1 to 7 by the patient. We picked these largely because there was a reference population of normal people who did not have cancer or a brain tumour, 16,000 normal Europeans who'd filled out this survey. So we knew what the normal population's health-related quality of life was, which is not, even though it's scored from 0 to 100, no one scores 100. So you need to know what the normal population is before you can tell if your patients have a worse health-related quality of life than the normal population. So what did we find out? We found out some really interesting things. What are the determinants of health-related quality of life? Well, poor overall or global health-related quality of life in brain tumour patients is most associated with poor subjective cognitive function. If you feel that your brain is not working, and make it clear that this is not objective, it's not tested, it's what the patient feels. If you feel your brain is not working, you will have poor health-related quality of life. Other things associated with global health-related quality of life are things like being unemployed, being unable to drive, being single, having seizures, being younger for your social quality of life, older for your physical quality of life, and anti-epileptic use. For cognition, this was most associated with communication, motor and visual deficit we can understand, but also things like fatigue, which we often don't manage at all, future uncertainty, pain and headache, sleep disturbance, and seizures. The ones that are in red are the ones that I thought realistically we could think about targeting in our clinic. I didn't put being single in red because I didn't think I was going to start a dating agency in my clinic. You never know. But we don't manage fatigue. As neurosurgeons, we never ask our patients if they're fatigued, and we don't manage fatigue, although there are interventions to treat it. And it's a chief determinant of health-related quality of life. So we looked at it obviously separately for each of the tumour types. So this is these have all been published. This is for low-grade glioma across time. These patients, the light grey is the normal population mean. So you can see no one scores 100, even if they're normal, healthy people. But for global role, emotional, cognitive and social quality of life, these patients all score well below par in low-grade glioma. And these things are sustained. Things like poor cognitive function and fatigue continue for 5, 6, 7 years after surgery. So these are important sustained determinants of health-related quality of life. In meningioma, we all think meningioma, these patients, of course, they have great quality of life. This is a post-operative series. Most of these patients were surgically cured. And yet, particularly for cognitive function, a really big deterioration in the patient's perception of how their brain works. And things like fatigue and sleep disturbance extend over 5 years. So surely vestibular schwannoma would be okay, right? Cognitive function in vestibular schwannoma should be normal. The patient should feel that their brain function is normal. But no, cognitive function had sustained deterioration as felt by the patient for acoustic neuroma, as well as social function and fatigue, which was sustained over 5 years. So clearly something is going on. The first thing we thought we should do is, should we check whether the patients really do have deteriorated cognitive function? So we used Cogstate, which is on an iPad, a quick screening 20-minute neuropsychological test. And what did we find? Did we find that our patients had cognitive decline or not? Actually, we found that most of our patients scored within the normal range. So anywhere between 90 and 110 is normal on this scale. So all of our patients, for the various different tests that we did, perhaps a little bit of loss of memory, which was statistically significant, but still in the normal range. But in general, these patients, their brains were working. If we mapped that against their perception, so their tested cognition versus their perception of their cognition, we found a really big disparity. So look at these patients down here. They're scoring themselves 0 out of 100 for their perception of their cognition. This is the QLQ-C30 cognitive scale. And yet here on the objective Cogstate scale, they're scoring within the normal range. So they think that their brain is seriously impaired, and yet they score normal on the range. Even here, these people are completely in the normal range, but are then scoring themselves less than the population mean. So what the patient feels is not necessarily what the truth is. That doesn't mean we disregard it. It means that we need to be thinking about what could be causing the feeling for them that their cognition is altered. And when we tested that against something like anxiety, so along with the same time as doing objective cognition, the QLQC30 and the hospital anxiety and depression scale, what we found was that actually so firstly, for this one, you can see here that the patients, their objective cognition and their quality of life, there is no correlation. But if you map the perceived quality of life against their global quality of life, there's a big correlation. But what if it's not correlated to how you measure their cognition? What is it correlated to? Well, it's correlated to depression and anxiety. If you are depressed or anxious, you will perceive your cognition to be poor. It's also true of fatigue. If you are fatigued, you will perceive your cognition to be poor. So that means that we should be able to target depression, anxiety, and fatigue to make these patients feel that their cognition is normal and to help their health-related quality of life. And yet we don't do that as neurosurgeons. So out of this research, what were the important questions that came up? So are these results generalizable? Is this the same in Vietnam and in India and in Australia, or is it different? Are there biological substrates of things like fatigue and other things that affect quality of life? What makes a patient with a brain tumour fatigued? Can we predict who will have poor health-related quality of life? So then can we do something about it? So we did find someone who had the same data set as us in India. So Dilip Panikar actually has been measuring the same quality of life outcomes for his meningioma patients as we have. And so we were able to combine and compare the data sets. Now, India and Australia are very different in terms of healthcare expenditure, risk of poverty after surgical treatment, the Human Development Index rank, which is a measure of education, health spending and GDP, number of doctors, number of nurses, very different health systems. Although having said that, where Dilip works is a educated private system in the most literate state in India. So that does, but still we found, and that you only need to look at one thing here. The Indian patients, while the Australian patients' health-related quality of life remained the blue here, very poor over time, the Indian patients started in the same place, but they got better very quickly. They're clearly much tougher than Australians, and they just got back to their normal health-related quality of life very quickly. And we've talked a lot about why this may be, and I think it's partly because you just have to get back into life in India. There's no being on a pension for the rest of your life. And if you complain of a symptom, the doctor will do a test, which you have to pay for. Whereas in Australia, you can complain of symptoms for the rest of your life and you'll get treated. So it's very interesting, but it's not generalizable. It's actually culturally specific. So that was a very interesting thing to know. Are there a biological substrate of these changes, like changes in fatigue, changes in cognition, changes in mood? And yes, there probably is. This is Heidi McAlpine. She's a neurosurgery trainee in Australia and my PhD student. And she's been patch clamping, so recording from single neurons in the brain around brain tumours. And she's found out that those neurons are not all the same. Their firing properties are different. So this shows neurons in high-grade glioma and in low-grade glioma. And neurons in high-grade glioma are much more excitable, and they've been changed by the brain tumour. And so the brain is changed by the tumour, and probably her later work shows that the electric activity in the brain actually makes the tumour grow. So there's an interchange between the tumour and the electrical activity of the brain, which is really only starting to be elucidated now. But this is going to change the way we look at brain tumours. Can we predict who will have poor health-related quality of life? This is Rashan Carey. He's a medical student, or he was a medical student then, who knows a lot more about maths than I do. And he made a machine learning algorithm using our data set to show whether he could predict which patients had reduced health-related quality of life at 1 year. And yes, we can. So, this patient here, who has much worse prognostic indicators, being male, being single, having, an unresected tumour, a grade 3 tumour, needing radiotherapy, we can predict that that patient will have worse health-related quality of life than the patient with a completely resected grade 1 tumour who has no seizures. And so this is something that we can use now to say, this is the patient we should intervene early. This is the patient that we can make a difference. And then lastly, what we were talking about before with our online, this is my last point with our online module, we can't possibly have enough allied health, supportive care, palliative care people to look after all of our patients. So what can we do that can do it more efficiently? So Heidi McAlpine, again, some work which started more than 10 years ago now, where we thought maybe we could have an online intervention. So she did a literature review looking for online interventions to improve health-related quality of life in patients with brain tumours. We found hundreds of articles that described an intervention, but only 13 articles that were rigorously assessed for value. So either a pre and post test or some sort of testing to see if they worked. Of those 13 articles which we published, we found that most interventions online had no effect. A few had a short-term effect, and a couple were actively harmful. They actually made the patient feel worse. So it shows that we needed to think about this carefully. So then we assessed all of our patients in the waiting room again, 200 patients with our army of medical students and iPads again, to do a survey looking at their social media use to manage their brain tumour. And we found out basically that these patients in Australia, they're isolated geographically. 50% lived more than 10 kilometres in the hospital, but 34% lived more than 50 kilometres from the hospital. So it's difficult for them to come and see us, to come and be involved in any supportive care. 50% didn't drive, 71% not working. So, these are patients who are socially isolated because they're not working, they might not be partnered, geographically isolated. But what did they tell us about an online intervention for brain tumours? They told us they wanted to control the amount and type of information that others knew about them. They wanted to know everything about everyone else, but they didn't want everyone else to know everything about them. So that's a little bit difficult to work out. They liked, obviously, the convenience. They wanted to use it as a guide and filter, because Google has so much information that you can't tell what's trustworthy or not. So they wanted to know what information's trustworthy. They wanted a health professional moderator or contributor, and they wanted to be able to share experiences with other people in a similar situation. And so that's where we came up to the platform that I was talking about before, Brain Tumours Online, which connects patients, carers and clinicians with information, with social media and with symptom management. We have done that through a co-design process. So we did our literature review here, and this was a process here where with brain tumour patients, with carers and with clinicians, we went through this cycle of continuously designing our platform and changing it until we have a prototype. And we're at this point here. Platform is now released and is enrolling patients for ongoing analysis and change. This will be a really interesting piece of information in this black box, because no one really knows how to properly evaluate an online intervention. We know how to evaluate a drug in a clinical trial with phase 1, 2 and 3, but how do we evaluate an e-health intervention? So this is going to be really useful information. So I've already talked about our 3 pillars, the learn pillar, the toolbox and the community connect pillar. And so we're in the evaluation phase of this, and hopefully this will allow us to change the health-related quality of life for our patients. Thanks very much.